Hi, Semester 4 students. I thought instead of doing a Facebook Live study group, what I would do is something a little bit more structured since this is a lot of material and it's fairly complicated. So what I'll do is do a quick overview on each of the concepts you learned this unit, and you should be able to access that on the Academic Coaching YouTube page. So without further ado, let's get started. Let's start with acute respiratory failure or acute lung failure. Objectives are taken strictly from the objectives listed in the course on Canvas. Clinical manifestations of respiratory decompensation. There really are three different categories. There's inadequate airway, inadequate ventilation, and inadequate gas exchange. And you may see different clinical manifestations or different signs and symptoms depending on what the problem is. So in an inadequate airway, your patient will have noisy respirations and stridor, which is, that high-pitched upper airway wheezing kind of. You may see retractions in the ribs, nasal flaring, and then the patient will be working really, really hard to breathe, and they'll be using those accessory muscles. In inadequate ventilation, you actually may not see the chest wall rise or fall. You may not see the patient breathing through their nose and mouth. That should be a pretty clear indication that your patient's not being ventilated. You may see manifestations of an obstructed airway. You may see central cyanosis. So, of course, the blue tinged lips is what that refers to. But on the exam, we know that Colleen uses words and phrases interchangeably. So she may say circumoral cyanosis, or she may say blue lips. We don't really know. If your patient's hypoxic, they could be very anxious or confused and restless. What you'll see in ABGs, your patient will be in respiratory acidosis. So you'll see a low pH, high CO2 levels. And then in inadequate gas exchange, the patient will be tachypnic, again with the central cyanosis. If a chest x-ray is done, you may see some infiltrates. Characteristics of ARF and ALF, you should know that by now. I'll just kind of linger on this section for a little bit. Mortality rate in Erden does say 30% to 40%. I think I would disagree with that based on what limited experience I have in practice, but that's what Erden says, so we'll just go with that. Hallmark sign of ARF, hypoxemia, that will definitely be on your exam. Hypercapnia you might see hypercapnia, but hypoxemia is the hallmark sign of acute respiratory failure. Be sure you know that. That's usually caused by a BQ mismatch. Different types, type 1 and type 2. In type 1, you'll see a low PaO2 and a normal CO2. In type 2, you'll see a low PaO2 and then a high CO2. Just some vocab I listed here. You should, your test is tomorrow. You know this stuff. So I'll kind of breeze right through that. Etiology or causes of respiratory failure. If I accidentally call it renal failure, I apologize. Sometimes my mouth says things without my brain realizing. So it's something I'm working on, but we'll keep going. Causes, extrapulmonary, so outside of the lungs. Causes could be like a spinal cord injury, neuromuscular problem, upper airway disease. Intrapulmonary causes, obviously, inside the lungs. So lower airway problems, alveoli problems, problems with the alveolar capillary membrane. Usually diagnosed, ARF usually diagnosed using ABGs. We won't really go over ABGs in much detail because you guys started learning it in semester 2, and I think Colleen did a pretty darn good job of drilling it into your brains up through last semester and even into this semester. So you should feel fairly comfortable with ABG analysis. If you don't, look on the Facebook page. I've posted some videos on ABG and interpretation last semester, which I really like those videos. Assessment, clinical appearance. We talked about the signs and symptoms a little bit earlier with the circumoral cyanosis, tachycardia, shortness of breath, all that kind of stuff. Medical management, obviously, if your patient's not getting enough oxygen, you want to provide oxygen therapy. Gold standard for any patient is your O2 sats need to be maintained above 90%. 90% always, and every disease process, every infection, all the things, all the time, O2 sat should be 90 or greater. Ventilation, examples of non-invasive ventilation would be like CPAP and BiPAP. If your patient's experiencing acute respiratory failure, I don't think CPAP and BiPAP would be first-line therapy. I think what you'll do is move directly to intubating the patient. Obviously, you wouldn't be doing the intubating. You could be asked to assist the intubating. You could, pull out the stylet or help with the glide scope or whatever. But anyways, you wouldn't be doing the intubating, but you should know vent settings. So mechanical ventilation really is what ends up happening. But of course, because you are in nursing school and this is an exam, you start low, go slow. So you try non-invasive things first, like CPAP, BiPAP, and when that doesn't work, you move to mechanical ventilation. In practice setting, of course, you defer to what the physician says. Vent settings really depend on patient condition and diagnosis. So acute respiratory failure, usually vents start off on assist control mode and then you go from there. Just for the purposes of this exam, with acute respiratory failure, you start with assist control mode. Pharmacology in ARF, bronchodilators, obviously to open airways, steroids, you want to decrease all the inflammation in the airway. Sedatives, if your patient's hypoxic, they could be anxious, so you do want to offer sedatives to kind of comfort them, calm them down, and you want to decrease their work of breathing. Analgesics for pain control, neuromuscular blockade that causes paralysis. Precedex, I believe, is one. I'm not sure if you learned about it in class. Anything to facilitate optimal ventilation. So I sure as heck know on your exam you'll probably have a question about high Fowlers, sitting the patient up at 30 degrees or higher, that kind of thing. Acidosis, patients in respiratory acidosis. Erden said sodium bicarb is not recommended even for a patient with a pH less than 7.2. So sodium bicarb isn't recommended because respiratory acidosis will continually be a problem until the underlying disorder is fixed. So fix the underlying problem and the respiratory acidosis will correct itself. Nutrition, patient will probably need TPN. They'll need a central line, TPN, that kind of stuff. Complications, anytime you're dealing with ischemia, you want to think heart, brain. So heart, you could have an anoxic brain injury where the patient, their brain isn't being perfused. The heart's a remarkable organ where, it takes 20 minutes until anaerobic metabolism really sets in, and before ischemia really becomes a huge issue, the brain doesn't have that reserve. The brain is very sensitive, much more so than the heart. So, anoxic brain injury can definitely happen very easily. And then I think we've all in practice encountered in clinicals or in practice if you work as a CNA, a patient that has experienced an anoxic brain injury because they never quite returned to baseline. There are some mental deficits there, definitely. Cardiac dysrhythmias, obviously, because ischemia. You want to think of, and your bedridden patient, whether it's respiratory failure or ARDS or any patient that's bedridden, mechanically ventilated, you want to think VTE prophylaxis. So you want to do the passive range of motion. You want to have the SCD boots on the patient in bed or TED hose or whatever. The patient will be on Lovenox, among other blood thinners, depending on what the condition is, because they are such high risk for clots. Another complication of renal failure, or I'm sorry, not renal failure, respiratory failure, or really any time the body undergoes such stress, or bleeding stress ulcers. So your patient could develop a GI bleed. That's why you kind of want to be monitoring the hemoglobin every day when it's drawn. Artificial airway complications, ventilator-acquired pneumonia is a huge complication in intensive care units. So oral care is very, very, very important. Make sure the head of the bed is sat up while your patient's being ventilated. Make sure tube feeding is turned on hold before you reposition a patient. Patient will be on some sort of PPI to prevent reflux. Nursing diagnoses. Now, Colleen loves nursing diagnoses, so you can definitely bet that there will be nursing diagnoses on the exam, and the questions won't be framed like which is most appropriate, or maybe it could. I don't know. If I were writing the exam, I think I would focus on priority nursing diagnosis. So, in your nursing diagnoses questions, anything that's priority, think A, B, C's. Airway, breathing, circulation. If it's an airway problem, then that's going to be your priority. If it's a breathing problem, then that comes secondary to airway. I mean, obviously. So be sure to keep those in mind when you are prioritizing your nursing diagnosis and even your nursing interventions and actions. Nursing management to optimize oxygenation and ventilation. You position, according to the book, you position the patient depending on what kind of VQ mismatch they are encountering. So just remember, you place the least affected area down. So least affected lung down. Just remember that. Reposition the patient every 2 hours. Least affected lung down. I don't ever really remember doing this in practice. It's more of like a stabilize and then reposition every 2 hour type thing. But this is what Erden says. This is what Colleen says. This will be on your exam. Reposition the patient every 2 hours because they do have risk for impaired skin integrity. So you want to reposition every 2 hours to decrease the chance of bed sores. Let's see. Preventing O2 desaturation. Perform procedures only when they're absolutely necessary. If your patient is incredibly unstable, don't go in and decide you're going to do a bed bath. You know, the old adage that you reposition a patient and shortly after they die, that's absolutely true. That is a thing that happens because you're then moving the patient, an unstable patient, and yeah, just don't do it. If your patient's unstable, then leave them alone. Only really turn them, reposition them every 2 hours, like move them very minimally. If you have to suction the patient, which you will probably have to do frequently, you want to hyperoxygenate before you suction them, which on the ventilator, I'm sure Carrie showed you, or Mark, the respiratory therapist who did your talk, I'm sure he showed you, but there is a big button on the ventilator that says 100% O2. You just push said button and then you suction the patient. Provide rest and recovery time. Minimize oxygen consumption. So when you minimize oxygen consumption, you also want to minimize their physical activity after they've been diagnosed and they've been on the unit for a while, and let's say they've been extubated. You still want to minimize their physical activity. No, I mean, they can get up with physical therapy to build strength, but yeah, you don't want them moving around a whole bunch because they're just going to keep consuming oxygen and they're already pretty stressed. Their body's already pretty stressed. You don't want to make a bad situation worse. If the patient's still really anxious, you can offer sedation. You can titrate those drips. So be aware that that is definitely something you could be doing. You want to control the fever, obviously, because the patient will be tachycardic, and that will increase oxygen consumption. And then obviously always be watching their pulse ox. If they're in for any sort of lung issue, you want to watch their pulse ox. If they're in for any sort of heart issue, you want to watch their heart rhythm and rate. I mean, it kind of goes without saying. Secretion clearance, supplemental oxygen if they need it, suction if they need it, hydration if they need it, which I think we all do. Make sure the head of the bed is up 30 to 40 degrees. When the patient is actually extubated, make sure they're deep breathing and they're using their incentive spirometer. Cough, deep breathe. I don't remember if Kathy Tierney ever came to talk to your class about her family member that died, and it was actually he survived a trauma, and I was very coincidentally working that trauma. He survived the trauma and then later died of pneumonia because he wasn't told to cough and deep breathe and use his incentive spirometer. And so he actually ended up developing complications from the trauma, which was, the pneumonia, and he did not make it. So while that's something that's drilled into our heads in nursing school, and it seems really like duh, like why wouldn't you do that? It's definitely something you want to encourage your patients because they don't know that. And that's definitely something you want to encourage your patients' family members to encourage because the patient might listen to a family member but not their nurse. Oh yeah, pulmonary rehab. Patient will be in cardiopulmonary rehab. Once they are discharged, they'll be on a workout plan. This is just a summary of everything that we have talked about. And then if you are a chart person, this was taken from Erden, page 515. It's a little blurry, but it's on page 515 if you want to see it. If you are a chart person, I am not. This looks like this belongs like on a serial killer's wall or something. I'm not a fan of it, but some people are, so I just thought I'd add it. Here are clinical manifestations of ARF by system. So I've got, your hypoxemia and hypercapnia, and then what you'd see by system. So central nervous system, cardiovascular, pulmonary, renal, GI, skin. I wouldn't memorize all these. If you guys can understand what's happening in the body, you should be able to then understand what's happening in each system. So if your patient's hypoxic, they're going to be tachycardic and have a bounding pulse. And if you can understand why that happens in hypoxia or hypoxemia, then you'll be fine. You can think your way through kind of backwards what's occurring in the central nervous system, what's occurring in the cardiovascular system, and the pulmonary, and the skin, renal, that kind of stuff. So this, in a nutshell, was acute respiratory failure. I hope this was helpful. If you have any questions, text me. I have clinicals tonight until 6 p.m. and then I'm lucky enough to take out sutures on my father-in-law's face later. That shouldn't take too long. But if you have questions, text me, email me. I'll be around this evening. So yeah, with that said, be waiting for more videos.